Short nail specifications. Phi 9 Phi 12 mm, length 180 to 240 mm. Long nail specifications. Left and right specific. Phi 9 Phi 11 mm, length 322 440 mm. Place the patient in the supine position. To facilitate intramedullary access, abduct the upper body toward the contralateral side by approximately 10 to 15, or alternatively, adduct the affected limb by 10 to 15. Determine the length and diameter of the main nail using a radiolucent measuring ruler. A long nail is recommended whenever possible. For fractures distal to the lesser trochanter, use of a long nail is mandatory. At the entry point tip of the greater trochanter, insert a threaded guide wire. Using the Phi 16.5 proximal cannulated drill sleeve and guide wire aiming device. Confirm guide wire position under AP and lateral fluoroscopy. If the position is unsatisfactory, adjust using a multi-hole guide wire aiming device. Remove the guide wire aiming device. Use a Phi 16.5 cannulated drill to open the proximal cortex along the guide wire to the predefined depth. Alternatively, manual proximal reaming may be performed using a reamer. Insert the reduction tool into the medullary canal and advance it across the fracture site. Insert the ball-tipped guide wire through the reduction tool into the distal medullary canal. Then remove the reduction tool. Perform reaming over the ball-tipped guide wire using flexible reamers, starting at 8.5 mm and increasing in 0.5 mm increments. Ream the medullary canal to a diameter at least 1 mm, larger than the selected nail diameter. Flexible reamers must not be reversed. Withdraw the reamer to remove intramedullary debris. Connect the insertion handle to the main nail using the connecting bolt. Insert the main nail into the femoral medullary canal over the ball-tipped guide wire, applying gentle rotational movements. Advance the nail to the appropriate depth. If necessary, attach the nail impactor extractor connector to facilitate insertion. Confirm the final nail position under AP and lateral fluoroscopy, ensuring optimal positioning of the helical blade within the femoral neck. Mount the proximal aiming arm onto the insertion handle. Insert the helical blade sleeve, 3.2 mm guide wire sleeve, and 3.2 mm trocar into the aiming arm. Adjust the rotation knob, make a skin incision, and advance the blade sleeve until it firmly contacts the bone surface. Remove the 3.2 mm trocar and insert the 3.2 mm threaded guide wire. Under AP fluoroscopy, confirm guide wire position. The guide wire tip should be 5 to 10 mm short of the subchondral bone of the femoral head. Measure the insertion depth of the guide wire and record the value. Remove the guide wire sleeve and use the helical blade lateral cortex drill over the guide wire to open the lateral femoral cortex. Remove the cortex drill while maintaining the guide wire position. In patients with dense bone, pre-drilling of the blade track is recommended. Adjust the depth stop to the measured value and drill into the femoral neck along the guide wire. Connect the helical blade to the insertion instrument. Note: counterclockwise rotation unlocks the blade screw and secures the blade to the inserter. Advance the blade through the drill sleeve along the guide wire, using gentle hammer blows with the slide hammer. Once the inserter and outer sleeve reach the preset depth stop, rotate the inserter clockwise to lock the helical blade. Fluoroscopic confirmation required. Then disengage the inserter from the blade. Remove the inserter, drill sleeve, and guide wire to complete blade insertion. Example shown with a 180 mm nail. The following section describes the operative procedure for oblique distal locking. Align with the static marking 170 to 200 static line on the proximal aiming arm, and insert the triple sleeve system protection sleeve, drill sleeve, trocar. Make a skin incision, position on bone, and remove the trocar. Drill with a 4.0 mm drill bit through the far cortex. Measure screw length and insert the appropriate 4.7 mm locking screw. The screwdriver connection may be secured using the suspension bolt to ensure stability. Once the screw is fully seated, the screwdriver connection may be secured. Release the internal shaft to disengage the screwdriver. Attach the 90 static aiming device to the handle and follow the 90 static line. All subsequent steps are identical to the oblique static locking technique. Align with the dynamic line and perform the same steps as static locking. Remove the insertion handle and aiming arm. Insert the end cap using the end cap wrench along the axis of the nail. Remove any ingrown soft tissue from the recesses of the end cap and locking screws. Remove the end cap using the end cap wrench. Remove the helical blade using the blade extraction instrument to prevent rotation or displacement. Attach the extraction rod to the proximal end of the nail. Remove the distal 4.7 mm locking screws using an SW 4.0 wrench. Extract the main nail by applying gentle slide hammer blows to the extraction rod. The following section demonstrates the distal locking procedure for the long nail. The helical blade insertion procedure for the long PFNA is identical to that of the short nail and will not be repeated. Long nails are available in left and right configurations. The following demonstration uses a left-sided 380 mm nail as an example. Sequentially attach the 3 aiming devices and secure them to the insertion handle using the locking nuts. Insert the targeting pin and targeting rod sleeve into the positioning hole of the distal platform. Position on bone and remove the inner rod. Insert the 5.2 mm drill sleeve and drill a 5.2 mm hole, stopping after penetrating the near cortex. Remove the 5.2 mm drill bit. Use the 5.2 mm flatten the drill to clear bone debris. Remove the flat drill and drill sleeve. Insert the targeting rod and secure it in position using the locking block. Rotate the movable block at the distal end of the extension rod to the static hole, static position. Insert 2 4.7 mm locking screws. The implantation technique is identical to that used for short nails. If dynamic distal locking is required, rotate the movable block at the distal end of the extension rod to the dynamic hole dynamic position. Insert 1 4.7 mm locking screw only for dynamic locking. Insert the other locking screw in the same manner. To allow direct visualization of cement injection and distribution, an ex vivo demonstration is performed. Insert the helical blade to the optimal position, following the standard procedure, and complete blade locking. Remove the blade insertion instrument and withdraw the 3.2 mm threaded guide wire. Fill the cement syringe, sleeve completely with the prepared bone cement. Adjust the depth stop on the cement sleeve according to the length of the helical blade. Use the cement sleeve in combination with the sleeve protector. Insert the cement sleeve through the helical blade sleeve and advance it to the appropriate depth. Confirm the correct position of the cement sleeve under fluoroscopy. Once proper positioning is confirmed, begin cement injection. Observe the anterior outlet opening at the distal end of the cement sleeve. Slowly advance the cement plunger from the proximal end of the sleeve, injecting approximately 1/3 of the total cement volume. Then pause. Rotate the cement sleeve by 120. Advance the plunger again to inject the second 1/3. Rotate the sleeve another 120. Complete the injection by delivering the final 1/3. Verify the cement distribution under fluoroscopy. Confirm that the cement is contained within the femoral head and that no intra-articular leakage is present. Procedure completion.